Okay, so our session today is going to be challenging cases in diversity, equity, and inclusion, specifically focusing on managing the micro and macro aggressions. And my name is Andrew Spector. I'm the chair of the AASM's DEI committee. I'm joined today by Dr. Kyra Clark, who is vice chair of the committee. Let's see. And together we have no conflicts of interest for this particular talk. Okay, so the format for today, and this is kind of a unique format, we've got 5 case scenarios that deal with different micro or macro aggressions. And each scenario is going to ask you for your response to the scenario, to the situation. And what we're going to do is we're just going to read the case and then pause. And while we're pausing, you're thinking about how you would respond to the situation, and you're going to type it in the chat, okay? But you're not going to press enter. Wait till I say the word, because what we're going to do is get everybody to respond at the same time once you've had a chance to type your response. And that way you don't have to wonder, okay, I don't want to say what someone else has already said. It's okay that way, because there may be duplicate responses, and that's fine. So we're going to take a pause after we read a scenario for you to think about it, type your response, and then all at once we'll type our responses in, and then we're going to discuss what people have said. And then on the next slide, as we go through the slides, we're going to change up the scenario a little bit and see how different elements of the scenario might change your response, and then have a discussion. And like I was just saying, that the whole format will work better if people are participating. This was not designed for Kyra and I to be talking to you, okay? We're moderating a discussion about these things. And there isn't going to be a right answer. We're not trying to get to the right answer. There's more than one way to do these things. So I just want you to be creative. You can talk about things you have done, things you might do, and we'll facilitate the conversation as things go. So thank you all for coming today, and I hope you'll participate with us.
Okay, let's just go through some baseline definitions. So microaggressions are perceived verbal, nonverbal, slights, snubs, insults that are usually unintentional, or even can be an insensitive question that communicates negative messages to one individual. So microaggressions are usually to an individual. Now the impact on microaggressions is big because essentially these become compounded over time. And the difference is the macroaggression essentially is an overt act of discrimination towards everyone of a particular group, and race, gender, etc. And this is on a large scale, larger magnitude. Next slide. So who are the actors when we talk about microaggressions, macroaggressions? Basically, we have the source is the individual doing the aggression. We like that term better than the perpetrator, but essentially that's the same person. In addition to that, the recipient's going to be the individual that's receiving the aggression from the source. And then lastly, we have the observer, the person who is essentially the bystander or witnessing the aggression. Next slide. So you are, and we're going to review scenario number 1. Let me get rid of some of my folks here. So you are a nurse practitioner in a large academic sleep medicine practice. You speak fluent English, but with an accent that identifies you as having learned English in school in China. Walking past the front desk in your clinic, you overhear the nurse manager telling the scheduler to book a patient with your colleague who was born in the US because that patient will want a provider who speaks English. How do you respond? So now, as Andrew stated, we'll all type our responses in the chat. I'm going to give some time. And then once I say, send, then everyone will press enter. Okay, type your responses in the chat, everyone.
Type it, but hold off pressing enter. We'll do it at once.
I apologize. You guys, I'm so
It's reflex. It's just reflex.
It is. I am so sorry. Okay, silence. I'm sorry.
Give you a few more seconds. Okay. So for those of you who are just joining us, welcome. I'm just going to review again the format if you missed it. We're going through different case scenarios that involve micro or macroaggressions. We're typing our response to the scenario that you see on the screen, and then in a minute we're all going to press enter and have our comments up there at the same time. We'll go through and review the different perspectives. Now this is a conversation and a discussion. So if you want to come on camera, on microphone, we'd love to have you participating in the conversation. This is not designed for us to talk at you. We want to talk with you and hear your ideas and hear your thoughts, and we'll discuss with you. So please feel free to join us in the conversation. And with that, let's go ahead, and everybody who hasn't yet pressed enter, go right ahead, and we'll see what different people are saying about how to handle this particular scenario. So Kyra, you jumped in first there. You want to go through your comment?
Sure. Basically, I always, whenever, if I'm the individual, I'm the nurse practitioner, I always try to ask for intent and clarification. But not in a public, not in a public forum. So essentially, after she said whatever she needed to say, I would, ask if I could speak with her and give a probing question, something to the effect of, I overheard you commenting on, booking with my colleague because, they speak English, but I didn't know what you meant by that. Could you explain that to me? Because, and so I would just ask for some type of clarification, because again, that enables you to really understand their intent. And then also to be able to then express how you're feeling in reference to the impact on you.
I think I was thinking similarly. Willie, what you want to go through your answer?
So I have never experienced this in person. I've overheard it actually, like in clinic. In this is just really just what I just copy and pasting like what the physician said at the time. Was that is there a particular reason why you're asking for someone who speaks English? Because it was very clear that the nurse was able to speak English, or the physician was able to speak. In that case, it was a resident who was Iranian and has a little bit of accent.
So you've actually seen this. You've seen this scenario hit home. You've seen actually something just like this happen.
Yeah.
Yeah. And actually, this is not the exact story, but I did pull this from a real life example of difficulty with accents in clinic. So I've seen something similar to this also. Yeah, there is the other way of going about this, I think, would be if you wanted to just, if you were handling it a little differently and you were the nurse practitioner, you could go up and say, oh, you know what, let me look, I can probably help that patient for you, and just sort of take over and see, because I'd be very curious to know how the manager would react when you're right there volunteering to see the patient.
That's interesting. That's another interesting approach, definitely.
Not sure that I would actually do that, but I'd be curious to see how the nurse manager would respond. I was thinking pulling the manager aside after the fact. I feel like it'd probably go better not in front of the scheduler if you wanted to have this conversation. Maybe privately ask for clarification. Same thing you were saying. Jennifer, what are your thoughts?
Well, I have had scenarios where I've just like heard some like a comment or shocking it. I just kind of not blunder in, but I'm pretty blunt in a way of playing dumb. Like I would have been like, oh, who is there a new person that works here that doesn't speak English very well? Oh, is there, I mean, that's the question I would probably ask, like, oh, is there someone near here who doesn't speak English? Oh, did the patient, request someone in, specific? So that's kind of how I just kind of play dumb, like, oh, what does that mean? Could you explain that a little bit? And said it hasn't happened in a professional setting, but like at a party or something where someone said something and I was like, and usually my response is, what did you just say? What did you just say? So that's just my communication style as well. So I probably couldn't help myself to just like jump in there.
So Teresa's going to charge extra for her accent. Are you willing to come on mic at least, if not on camera, and tell us more, Teresa? Are you not in a position to turn your mic on right now? It's okay if you're not. Okay. Well, we'd love to have you if you want to join us when you can. Let's change this up a little bit. There are some different variables we can change in this case. This nurse practitioner was from China. How does it change if that nurse practitioner is instead from Kenya? What do you think the difference would be?
No difference. Honestly, I don't think, well, personally, I don't think that my approach would change based upon a different, Kenya, Jamaica, France. Let's see what everyone else thinks.
Can I say something?
Oh, yes, please. Welcome.
Hi, I am Teresa Zyglewska, and I actually speak with Polish accent. I am a neurologist, and I was in successful private practice for many years, and it was my answer. And people liked, and people came next time to see me. And those people who do not appreciate our work, our extraordinary skills in medicine, they should go and see somebody else. And I would say to that nurse practitioner, of course, I am not nurse practitioner, I am MD, but to the scheduler, I would say that this is discrimination. This is America, and everybody is allowed, doesn't matter which country are we from. We are from.
So the reason I put Jamaica and France, for example, Jamaicans speak English as the native language and the French don't. But we have a different, we may, I don't know, you could be white or black or Asian or any other race from France, but let's just suppose it's a white French person and a black Jamaican. Let's just say that's the case with these people. Now you've got an element of racism in there because a Jamaican accent for a native English speaker versus a French accent in a white person. Who's going to face more trouble for their accent? Both are fluent English speakers, but one's actually a native speaker.
Again, if I can say, doesn't matter what skin color. We don't assess people by skin color. We are the same people, but we assess our skills. So if we are good, I would not put that race or China. Of course, now with China, with that virus coming, people more aggressive, but this is wrong. People are people. So I would really try to say to everyone involved that race does not have place. We are the wrong telling this even. Talk about this.
We'll change it up one more time. So we like to talk about calling in versus calling out. And this is a concept that I actually struggled with for a while, and I feel like maybe I'm starting to get better at. But it's a hard concept when you think about calling in the manager versus calling out the manager. So let's talk about how we would go about calling in versus calling out? What would be an example? Does someone have an example of either calling in or calling out the manager? Is that something, is that a terminology people are familiar with? Should we go through that a little more?
I think, yeah, I'm not,
Yeah.
I mean, I'm thinking I might know, but that's just
Mhm.
me guessing. So maybe if you explain that.
So the calling out response would be, hey, I speak perfect English. Why are you saying that? There's a bit more of a confrontational aspect to calling someone out. If not directly, then the next day, who's the manager's supervisor saying, hey, the supervisor, this manager did something that was offensive to me. You should talk to them. That's calling out. Whereas calling in might be, hey, I heard you say that, and I'm fluent in English. Can you tell me why you might have said something like that? And those clarification techniques we were talking about in that a couple minutes ago, that's more calling in. Let's get more information. Let's maybe give someone the benefit of the doubt when we can, versus and both are responses, and it seems that calling someone in has a greater likelihood of actually changing future behavior, explaining
Exactly.
why this was upsetting and so, but it's a burden that you put on people, because now not only have they suffered the microaggression of hearing this, they're also now responsible for being polite and calling in, and so it's an additional burden that's placed on people. And so it's a fine line to walk between the benefits in the long run and the burden in the short run.
And Andrew, what I found is that when we call in, it gives people the opportunity to kind of unpack what they've done, just to kind of check themselves. And so I agree with the burden that, people have to kind of take this as an additional step. But I found as though when you call in, people will say, wait a minute, I didn't mean it that way. And to be able to kind of really clarify what they've meant.
I would just say, like, my one thought would be just to make sure, because maybe the patient is really, really hard of hearing, and maybe someone with an accent, maybe it's harder for them to hear. That was like the only thing I could think of. Well, maybe, and then, but still, you could figure out a way around that, so maybe, I mean, there could be a reasonable explanation, but I would say it is hard to go the calling in way, because
it's asking a lot. And that's kind of why I'm going through the third point here, because maybe it's not the nurse practitioner who just suffered this microaggression as the recipient. Maybe it's not the recipient. Who are the allies here? Who could do this on her behalf so that the NP doesn't have to do it herself?
yeah.
I mean, Kyra says the scheduler. The scheduler is certainly the observer of this, although the scheduler may not know. They've just observed this because they don't know that there's someone, that the NP was observing it, the interaction. But right, certainly the scheduler, although there may be a power dynamic there between manager and scheduler.
But potentially, as you look for allyship, if you will, like that individual person, it's hard. It is difficult. Because again, if they don't recognize, then it's like, and also the power dynamic as well. But you could always do a clarification question, like Jennifer was saying earlier, like, oh, wait a minute, what do you mean by?
Mm-hmm. Well, I think this is also one of the key reasons that practices and academic departments, whether you're in private practice or in academics or wherever you are, need somebody designated to handle these types of situations. And that's a role that I play in my department at Duke. And that's how I even heard about this case in the first place, because the NP came to me and told me the story, asked for advice, and we handled it after the fact. She didn't handle it in the moment because she didn't want to. That's fine. But then we could go back and address it later, and she brought me in to help. And so, like in our department, we actually have local on-site diversity and inclusion reps, because I oversee them, but I can't be everywhere, right? And not everybody knows me, so they wouldn't be comfortable coming to me. So I have somebody in each clinic we have around town who's designated to be that ally. And I think any practice, any academic department, anyone could do that, but advertise who the allies are so that people can find them. Any other comments on this case? Selena, welcome. We're going through some scenarios. You're welcome to come on camera and microphone and jump in. We're happy to have you. This is a discussion.
Thank you. Sorry, I was a little late getting in, but
No problem.
I missed the scenario, so I didn't participate. So I'll just wait for the next one.
We'll go on to the next one. Let's do it. Okay, we got 5 and we're already 20 minutes in, so we may not even get to them all. Okay, scenario 2. You are instructing a female patient with cerebral palsy on how to apply a CPAP mask. The patient is accompanied by a woman of similar age. You comment that you'll teach the patient's sister how to help her put the mask on. The patient responds, "That's not my sister, that's my wife, and I don't need help to do this." How do you respond? So what we're doing is we're going to type our answers in the chat, but don't press enter. And then when we've all had a chance to type them in the chat, we'll press enter, and then we'll see everybody's responses at once. Everybody have something? You just nod, and I'm kind of watching the gallery here.
Oh, sorry. Hit send. I can't help it. It's just returned.
All right, we're going in now. Okay, who was first? Jennifer, were you first in there? You want to?
I think I was, yeah.
Go for it.
It's a tough one because there's like 2 errors right there. You're making
All right,
an
good.
assumption about their relationship, and you're also making an assumption of like how this other person, can manage things for themselves. So I would hope I wouldn't do that, but if I did, I would say, "Oh, I'm sorry. Yeah, I should have made that assumption. Nice to meet you. Glad you're here supporting your spouse." And also, let me know if you do need help with putting this on. I'm just going to show you how to do it, and you just tell me what you need. That was a double whammy. So.
Thank you for pointing out both of them. I was wondering, making sure that everybody caught both of them that are in there. So thank you for pointing those out, because yes, there were 2 errors made in there.
Let's see, who else chatted in? Teresa?
Yes.
Yes. Can you expand on your comment as far as what you would say?
I would say that I did not catch the first component. You are very right. I would ask the patient who has obvious problem with movements, but I would ask him, okay, it's okay then if I explain this to your wife, and I would kind of accept that this person is wife and would not comment, not apologize.
Good, good. I think everyone is definitely on the same page as far as, genuinely apologizing. And, owning it. That is so funny. Me and Andrew put the same thing, own up to it. Okay, fair enough. Selena. Selena, are you able to come on?
Yes.
Since you weren't able to talk in the last one?
Sure. Yeah, so I, obviously my first reaction was, apologize for making the assumption. And then also go on to, making sure that I've addressed, their concerns as far as, they said they don't need help, but still ask, try to see if there's any other way they would need any support as far as the instructions.
Good, good. Definitely. One other additional point before we go to Willie was that oftentimes when we apologize, we're listening to respond and not listening to truly understand what just happened. So that's why I tried to put in my response, listening for true understanding as far as whatever feedback or response that the individual has that just received the microaggression. Willie, are you able to come on?
Oh yeah. So it's basically the same as everyone else. But like I'll probably ask the patient's permission to, at the same time, like have some just general educations for the family on how to put CPAP on, just in case, for instance, the patient's sick in the future and they're at home, they need help. Yeah.
Okay, that's great.
If I can add, I would really, of course, it's very nice to apologize because we try to be nice to the patient. However, by apologizing, we would indicate that we did something wrong. We did not. The patient should introduce, this is my wife. How I should know? Wife, sister, who knows, right? So physicians, nurse practitioners, we are people. We need to be respected as well, not only beaten with the hammer, because all this race, all this difference, diversity, come on, we got to speak for ourselves as well.
That is a great point, Teresa. And what I've kind of got into the habit of doing is basically, since I, as I know the patient themselves, I'll say, with whom do I have the pleasure of meeting today? To put it back on the patient to introduce the other person to me.
It's true, but
my phrasing is to say to the patient, who'd you bring with you today? Who is, and yeah, and actually we're going to get to that in the next slide about mitigating strategies to avoid these things happening in the future, just like that. But I wanted to jump in and say, and say, there's always the difference between intent and impact, right? So I don't think that the person setting up a CPAP mask had any intention of causing any harm to this patient, but clearly the patient was upset by this. So, the reason to apologize is because regardless of our intent, we created a harm. And that's the case with microaggressions in general, that they're not usually intentional. If they're intentional, we tend not to call them, micro.
If I can jump to also, sorry if I interrupt you. However, if we are at the point that we are already showing mask or whatever, we pass the first stage of the interaction with the patient when we introduce ourselves as a provider and patient introduce themselves, and they should introduce whoever accompany the patient. And our role in the very beginning should be to ask the patient, who is that person? It is okay if we talk in front of that other person because of the HIPAA and confidentiality, right?
Right. So let's talk about, we talked about intent and impact, I guess. And then, so this is getting to exactly what you were just saying, Teresa, about what could we have done so that we didn't make this assumption later in the visit, right? We could have asked up front. We probably should have asked up front.
Right. This should be a habit, I think.
Right. We need to make sure that we're not assuming who these relationships are, but also from the physical standpoint, right? This is a woman who had some sort of physical impairment, and we assumed what she could or could not do. And so what kind of phrasing would you use when you're in the room with a patient to ask that question? What strategy would you say so that you don't just assume that you know what she's capable of?
I think that's when asking, is more like, so not just saying, here are some instructions and I'm going to show someone, is like, do you have any questions? Have you had any experience doing this, to kind of figure out where they are with it before trying to identify what support or resources they might need.
I would give that patient a mask and see how it does. If cannot manage, then say, oh, maybe you need help. It's okay if I show whoever accompanied you, right?
Or, you say like, I'll show you how it works. If at any point along the way, it seems like it's not going to work, you let me know.
Right? Right?
Yes.
Yeah.
Okay. So any further comments on this one? I think that's the last thing in scenario 2. Because we can move to scenario 3. Any further comments on this case? Okay. Oh, there is one more. Sorry. Oh yeah, I forgot about this one. How would you recover? So we've apologized. Do you think the apology is sufficient and you move on? Is there anything more that you would do to recover the relationship?
I mean, I would probably, if I was in this situation, say, I'm not going to make that mistake again. Just don't let like decades of indoctrination of what like we expect to see and assumptions we make. I would just say like, this is, like smack on the head. I would hope that would, show that you're human and that you acknowledge like, oh, that was just kind of just not paying attention. You need to pay attention.
And I think like basically thanking them for like calling you out on it, I think it lets them know like you're acknowledging like, okay, my bad, kind of a thing. And I think also Kyra's point about, listening for feedback is important here too, so that, again, letting them know you do sincerely care about how you made them feel and, that you want to fix it.
I love that, Selena. I think that's great. Thanking them for telling you. I think that's really good. What I would not do is try to overdo it, right? I wouldn't go into a whole discussion about how you're not homophobic and how you have this relative who is in a same-sex relationship and, none of that's relevant. And trying to defend yourself or your character is not going to get you very far.
Right. So the best, don't apologize. This is like normal, accept and move on. And then if they are not happy, they are a problem. Go and find somebody else. I would say like, not directly and not immediately, but come on. It's just accept as a fact. They are in different relationship and this is not my business. This is private.
That's right, Teresa. This isn't about you. So I totally agree.
Yeah.
Okay, so now we can move to scenario 3.
Okay, so you were the only physician assistant in a practice with 4 MDs. You observed one of the MDs standing behind one of the front desk staff giving a shoulder massage. The staff member is visibly uncomfortable. How do you respond?
All right, so we'll see if we can try this again to put our comments in the chat, and we'll hold off. We haven't done it yet, but we're going to try. Okay, you can nod your head or wave or something when you got answers in there. Okay, good. All right, ready? Enter.
Okay, good. Let's see what we have here. All right. So let me scroll up. Okay, we'll take a photo. Okay, wait a minute. Wait, I'm not sure. I'm on the first one. Okay, Selena. Let's see. Oh wait, who said something first? Okay, I'm gonna skip Andrew. Okay, Selena, could you just give us some comments on what you've put in the chat?
Sure. So the strategy was just to kind of separate them, but maybe not call them out on it, but, just in some way, shape, or form, get the MD away to make them stop. And then, kind of once that's gone, or when that person has left, then check in on the staff member, ask how they are and see if, they want to report to HR or do something like that. If this is an issue, kind of check on them and see if they want to take any steps to help protect themselves.
That's definitely a good point. Now, the one variable that I was also considering when I was doing this is maybe the power dynamic. So you're the only PA with 4 other MDs within the practice. But definitely, if you're bold enough, I'd be all for it to be able to, separate them. Teresa.
I am controversial here. I know.
Yes. No. I want to hear from you.
I know what the subject that is sexual harassment at work is baloney, is overblown. It is between 2 people. Maybe that person who was getting that shoulder massage had pain or spasm. I don't know what exactly going on. This is between 2 people. So that person involved should act and said, go away if that did not like that massage. And why it's like we make all big trouble is maybe that MD did not have any bad intention. You know what I mean?
Yes. I think Jennifer also has a similar, to basically call someone away. Jennifer?
Yeah, I mean, if I saw the person and they looked uncomfortable, I probably wouldn't want to blow it up in front of, I'd say, hey, could you come here and I need to show you something. And then I would say private, like, I don't think you should be doing that. The front desk person didn't like it. And it's, you might not have realized it, but it's just, you should not be doing that. And I would talk to the front desk person and say, like, are you okay? Because again, I would say, like Teresa just said, maybe it's fine and it's something they've done before and might be a look on our face for something else. But, I've also been in a situation where I had a boss that really liked to give shoulder massages and it wasn't a great situation for the people that work for him. So, because there is that power dynamic. If they're the boss, and they come up behind you at the front desk, it's a little awkward. So I think it would, I didn't have anyone like to do that for me. So I would want to be a help to someone else and make sure, because it might be unintentional. The person might be clueless. So make sure they realize, nope, can't do that anymore. It's not like 1972.
That's a great point. Definitely. Thank you for that, Jennifer. Now, Willie, you wanted to report to HR. Can you tell us a little bit more about how you would do that?
I feel like I'm just one of those people who's not sure like what to do and just sending to HR for HR to do it. There are so many ways that you can send an anonymous email, like without exposing your email or your identity. You can get that very easily just on website. You can potentially just send the photo and let, you have photos, you have like, the physicians there. So it's always I think it will be a better idea for someone in a, in a management position or whatever to deal with this kind of situation. If, in this case, I were just a simple assistant, I'll probably be likely to lose my job if I reported the person. That's my guess. Yeah.
Yeah, I can definitely see how you might feel like that as well. Andrew, any last comments on the responses?
Yeah, so mine was slightly different because I was calling to the staff person and not to the doctor. And I wasn't trying to get the doctor away. I was trying to get the staff person away. And the reason for that is because if I called to the doctor and the doctor came over, I was going to have a confrontation on the spot with why I did it. Whereas if I call the staff person, I can at least ask the staff person, was that bothering you? And get that critical piece of information before I addressed it to the doctor. Because I feel like, did the staff person ask? I assume not, but I don't want to go to the doctor until I have at least confirmation from the staff person that this was an unwelcome advance. So I wouldn't have to lie to the staff person. If the staff person came, if I called over, I could say, hey, I was just trying to get you out of that scenario. Whereas if I had called over the doctor, I might have to either confront the doctor, or it would have been a bigger thing right off the bat. So my strategy was to actually interrupt to get the staff person's attention first, because I just felt like it would be a smoother way to interrupt. But, our first three cases, the first one was a recipient, the second one was a source, and now we've got an observer, right? So, and I just want to keep that framework in mind as we're looking at when you're an observer. You could, your immediate job in any of these aggressive situations is to try to break the situation, right? End it, interrupt it somehow, walk right up to the front desk, whatever you need to do, noise, whatever, to just interrupt the scenario as it's happening.
Yes, great perspective. What other questions do we have, Andrew?
Now, in your heads, how many of you envisioned a front desk person who was female and a physician who was male? I mean, was that just kind of the default schema in your brain? Because we don't know that for sure, right? We don't know if this is, the case was ambiguous. I imagine many people probably had that in their head. How does this change if the MD is female? And it's a female staff person? Are you immediately thinking sexual harassment? Should we be, though? What do you think?
I would think I don't think I would change that much, because I think the focus is on the staff person looks uncomfortable. So even if it's not sexual harassment, maybe they're rough and they were hurting them, like it could have just been physical discomfort. But I think that just the point that the person was looking uncomfortable, and that was what you're trying to fix.
Right. I think we have to stay alert for that. Exactly what you're saying. It shouldn't change, right? It's not okay for anyone. But sometimes I think because of the schema in our head of how we envision scenarios, we don't necessarily assume it's sexual harassment if it's same sex, but it certainly could be. And so we should behave exactly the same way.
Exactly.
Now, what if you do have power? What if you're supervising the MD and not the PA? What if you're the named partner?
Well, as someone who's been through many training seminars for preventing sexual harassment, first thing I say, you gotta stop that, because this is a liability. You're putting our practice at risk. You gotta fix this. I would be coming from that, this is unacceptable, and you're putting our practice at risk.
And I think
I agree that originally I wasn't necessarily going to confront, the MD in being the PA, but if I'm a partner MD, I'm gonna definitely confront the MD in that situation. Selena, go ahead.
Yeah, thank you. Yeah, I was just going to say the same, because I know when I replied, you mentioned, well, the power dynamic. And so when I initially commented, I was more just calling I wasn't saying I was going to call the doctor out on it. I was just trying to get their attention, because of that power dynamic. But as someone on an equal footing as them, they could even, if they don't want to be confrontational, they could even take more of a playful approach, saying the same thing that Jennifer just said, hey, you know better than that. Come on, dude, or whatever, or, hey, you trying to get us shut down here, or, something like that. But I think it'd be much easier for that confrontation to happen.
It's amazing how you flip the power dynamic, and it just becomes so much easier to have that conversation, right? And when you don't have the power, it's amazing how that limits your options. So I think we've all commented on this already. We're all going to try to do something in the moment, right? I think everybody said we got to interrupt, we got to do something. Now, if you've interrupted, are you cycling back? If you're imagine you're the PA still, you don't have the power. We know Willie wants to send a photo of the event, so we know he's following up afterwards. What do you think? Is there more that we need to do as the PA? And when that comes to calling out and calling in, right? If we send a letter to the other partners in the practice, that's kind of calling out what we saw and not calling in. And what do we do after the fact once we've interrupted?
I think maybe some of the afterwards, steps would depend upon what the individual said as far as how that, yes, it was unwanted, confirming that. And then also, okay, well, do you want to go to HR? Do you need support to go to HR? So I think that that's kind of what would dictate my afterward steps.
Yeah, how receptive was that person to the conversation? Like if they were like, oh, I didn't realize, versus trying to deny it, I guess that would also inform my next steps. But again, if I'm not a person in power and I really need my job, it is difficult to do something.
And we got to remember that staff person's almost certainly worried about retaliation, right? It's not just the power dynamic for the PA, but it's the power dynamic for the staff person to report. And even if the PA goes and reports this anonymously, what makes you think it's not going to come back on the staff person? So before you go and report things, you got to think about what impact that might have on the person you're trying to help. And they may not want that. So I think the point is very important to talk to the person, the recipient of this, and then get advice before you take any specific action that may wind up making things worse. Okay, scenario 4. You are supervising a sleep medicine trainee. The trainee leaves the exam room after examining a patient and appears shaken up. The trainee tells you that they were made to feel uncomfortable due to inappropriate sexual comments made by the patient. How do you respond? So we flipped it up. Different power dynamics now. Are we about ready?
Yes.
Okay. 1, 2, 3.
All right, let's start with some comments. I'm going to skip my own and Andrew's. Okay, Selena, we'll start with you. What is it that you would do?
So I would obviously, not obviously, but I would focus on the trainee in that moment, because they would have been, they would have experienced the trauma in that moment, and I want to make sure they're okay. And then ask, any other support they may need. And then make sure that there would never be contact between that trainee and patient again. And then just kind of, I guess, depending on characteristics of the patient, I may or may not need additional help. I'm not really sure my position, but definitely find a way to confront the patient about it and let them know, like, this was inappropriate, and if they are going to receive care, they need to act appropriately.
Exactly. That's definitely the right step. I think we all would start definitely with the trainee. Willie, what comments do you have?
Really don't know what I should do actually. So definitely the first step will be comforting the trainee and trying to figure out what happened. And I guess will be depending on like what the situation is, we'll have to potentially intervene. Yeah.
Okay, good. Definitely it's, important to understand what kind of transpired, reinforced to the resident, because a lot of times when you have that power dynamic, the trainee was uncomfortable, and you want to basically talk to them to let them know that this is not okay, and just follow up on their welfare. So I agree with that. Andrew, what additional comments do you have?
Well, so I agree with something that Jennifer wrote too, which is tell them that they don't have to go back.
Yes.
But I also don't want to tell them they can't. You can offer to either go back with them and so that they can witness you having the conversation with the patient, or, the reason I say that is because if this is a case that the trainee wants to learn from, there's something that they want to participate in, they shouldn't be forcibly kept out if they don't want to be forcibly kept out. So I would give them the option and just say, there's no reason you need to go back. I can handle this. If you want, that's up to you, but just know that there's no obligation to do it. But also I wouldn't refuse to let them in either, I guess, because I don't want to make that decision for them.
That's good. Definitely giving them the option is, the right thing to do. I didn't necessarily write that, but I would have done that as well. Just like, but most often I had this scenario specifically in a residency program in which I was the staff person. I was precepting that day. And for that individual, depending upon the gender, maybe they wouldn't want to go back. I'm not sure. Because in that specific situation, she said, no, I'm not going back in for that patient. So I went in and handled everything appropriately. And actually that patient, because that was not the first time that patient had been inappropriate with, other residents, they were dismissed from the clinic.
And I think we need to be prepared to do that. I agree with you. And Selena makes a good point of making sure that they don't wind up blaming themselves and thinking that they invited this or did something wrong. I think that's a good point, Selena.
Exactly.
So again, we can change up the scenario. We've sort of analyzed this from different genders before. I'm going to skip this in the interest of time because we've only got about 5 minutes left. And let's see, we've covered it. With the patient, with the sleep fellow, we seem to have said that yes, we need to have this conversation with both of them. So let's see, we got 4 minutes, so we can squeeze in the last one quickly. Let's see, you want to do this one, Kyra?
Oh, sure. Yes, you are tasked with recruiting a new sleep medicine physician to your practice. Your managing partner tells you to not worry about all that diversity stuff and just get the most qualified person. How do you respond? Let's type.
All right, we ready?
Yes.
Okay, go ahead.
Okay, well, just for some final comments, as far as what we're going to do, Jennifer, I believe I skipped you from the last one. I apologize on that. What are your thoughts?
I mean, that's a tough one. I mean, I guess my approach would be like, okay, great. Well, let's do a blind review of all the applications. So like when we're doing this first, review, we're like totally focusing on everyone's qualifications. Like, so, but it's a tough one but you don't, I guess I haven't come across that. I've come across a lot of like terrible things. So we're like ready to, respond to that. But I would just like, how do you, for my approach, how do you make like, I want to make it a fair process. So, and looking at the applicants, and also you need to look at who the other employees are, because you need to balance that out. I mean, we're doing that, with an AASM where we're trying to build committees to see like what skill sets are missing. So diversity would fill some of those skill sets, when you look at it that way. So that's the best applicant for the job then.
So Jennifer, I've got a follow-up question for you. You said offer to do a blind review of applicants to ensure we get the most qualified. So the question then is, how are you defining most qualified?
Yeah, I thought about that when I was answering, because there are some things that are more subtle that you wouldn't know just by looking, at like an application and a CV with like the name and address blocked out. So I will say, I don't know if I have the great answer for this, but it's just qualifications. Having a diverse team makes your team better. So
right. So exactly. So you can't have one without the question you're being asked to do is inherently problematic.
Yeah.
Because how can you not look at the diversity of the team you're trying to fill if you're trying to make the most qualified team, right? Like that you can't do one without the other. So yeah, and broadening our definition of qualified is critically important, right? Qualified doesn't mean the name on your diploma, right? Qualified doesn't mean a lot of things that we have historically pretended it should mean, which sort of reinforces a certain homogeneity of our teams, right? And it's because we keep using the same criteria and finding the same people. And if we broaden what it means to be qualified, then all of a sudden a lot more people are going to be qualified, because a lot more people are capable of doing the job than we have historically allowed.
Exactly. I think Selena was kind of in line of, what Jennifer was saying as well, letting them know how important diversity is, valuing diversity, and that diversity benefits us. Yes. I know, I think my comment might have been a little snarky, like, do you mean qualified candidates can't be diverse? But I probably honestly would have asked, a question.
I'm with you. I did the same. What exactly does that mean? Diversity stuff, right? Like, come on, what do you really mean? What are you trying to say here? Yeah, but Selena, I'm with you. An objective review is very important. And I just emphasize that the objective things that you're using are broadly defined. And because we know of the bias in grades and test scores and so many things that put themselves out as being objective. And yesterday I got a question about how do you not use test scores, since test scores are the primary objective thing we have? The answer is because they're not as objective as people think they are. The most predictive thing for your MCAT score is how much money your parents make. That's the number one predictor of MCAT scores. So is that really how qualified you are, or really how wealthy your parents are? Willie, what'd you post here for us? What is this?
Sorry, I just it's actually just related to what you said regarding to MCAT. This was actually one of the articles, actually not just one of the articles, there are many articles talking about why MCAT doesn't really predict anything for the outcomes, including exams and things. Whatever, that's a whole different story. This is just one of the classic examples that the results it's there, like data is there, and it's supporting what people don't want to hear. Yeah.
Any final comments? Because it's 7:02. We've gone for an hour, so we've got to close.
Yes.
But any final comments? Well, thank you all for participating. Teresa, Selena, Willie, Jennifer, Kyra and I were really happy to be able to do this with you. And thank you for being such active participants, because the session only works with you guys participating. So thank you very much. Yeah, please reach out to us if you have any questions about the AASM and our DEI program at the AASM.